This case was performed without IV contrast to look for calcified renal stones, which could be missed otherwise if contrast was given. There is a normal appearance of both kidneys and the renal collecting system without calcified stones or hydronephrosis. Now, since the patient presents with left-sided pain, let's concentrate on that area. Have you noticed this abnormality? Let's follow this structure to understand what we're looking at. This is the rectum that becomes the sigmoid colon, which then continues as the descending colon. So this is air filling the lumen of the descending colon, and the abnormality is located at the region of the distal descending colon. Now, as we know from before, the normal fat, such as the subcutaneous fat or intra-abdominal fat, should be very clean, as you see here. This area looks a bit dirty. This dirty or strandy appearance is what we call fat stranding, which is a sign of inflammation. Once you see that, try to look for a cause. Now, since we have excluded renal stones, another potential cause for left-sided abdominal pain would be colonic diverticulosis with inflammation. So this condition, known as diverticulitis, is associated with inflammation of outpouching of the colon. It's very important to note here that there is no outpouching of the colon, meaning that we don't have any diverticuli. It's also important to note that the wall of the colon at the region of the inflammation is thin and is not thickened or hypodense to suggest inflammation of the wall itself. Finally, notice that this abnormality, which is anterior to the descending colon, has a central dark area that is similar to fat and a dense rim here that is surrounding by the fat stranding. This appearance is characteristic of an entity called appendigitis epiploica. If you remember from your normal anatomy, the colon was associated with fat tags that are attached to the wall. These fat tags are known as epiploic appendages. If the fat tags, the epiploic appendix, is inflamed, it's called an epiploic appendigitis. The theory is that the fat tag twists around its vascular pedicle, leading to such inflammation. And this twisting is painful. That's why if this happens on the left side, it could mimic diverticulitis, and on the right side, it could mimic appendicitis. This is good news to the patient. This diagnosis is not a surgical diagnosis. The treatment is observation and painkillers. This entity of epiploic appendigitis typically resolves spontaneously within a short duration. For the sake of comparison, let's look at a different case. So this is another patient who is 42, male, presenting with left abdominal pain. The CT was performed with IV and oral contrast. So similar to what we did with the previous case, let's follow the colon from the rectum and go more proximally. As you do that, you reach the sigmoid colon, which is a little bit redundant in this case, and then you reach the descending colon here. Here's another example where the subcutaneous fat is clean, the internal fat is clean, but the fat immediately surrounding the colon in this region is not. As we agreed before, this is called fat stranding, and it's a sign of inflammation, so try to look for a cause. Now, looking at the colon at a different location, you'll notice that you have several areas of outpouching. This is known as colonic diverticulosis. As you scroll, you're going to notice a few others as well here. And we reach the area of inflammation where the colon itself has a thick hypodense wall. This thick and hypodense wall is a sign of edema, and it tells you that the colon itself is inflamed. Here's another diverticulum, and even a larger diverticulum adjacent to it. Note how most of the stranding surrounds this diverticulum, and the diverticulum has a rim of hyperdensity suggesting enhancement and inflammation. Here's a coronal image showing the diverticula involving the left-sided colon with an inflamed ill-defined diverticulum and thickening of the wall in that region. Now that you're an expert, you notice that there is fat stranding around the same area of abnormality. More experienced people might have noticed that you have thickening along the fascia of the abdomen, which goes along with inflammatory fluid tracking there. All in all, this is a case of acute diverticulitis. To summarize, fat stranding is a sign of inflammation, and it's very useful to guide you to where the abnormality is. Once you see fat stranding, try to identify the cause. If the stranding surrounds the colon, try to identify whether the abnormality is arising from the colon itself or from something surrounding it. Thickening of the wall of the colon is a good sign that the colon itself is the primary origin of the abnormality, and seeing diverticulae tells you that this is a case of diverticulitis. However, remember that this neat entity of appendicitis epiploica may confuse you for other abnormalities. Now, appendicitis epiploica has a classic location close to the colon, has a central fat area, and is surrounded by inflammatory changes. Importantly, the wall of the colon in such cases is normal and not thickened, telling you that the abnormality is from outside. Thanks for watching. See you later this week. The first important finding on this CT scan is the asymmetric appearance of both breasts. This is a patient who's young and who is expected to have dense breasts, but the asymmetry raises a concern. Comparing the right breast to the left reveals that the left breast has this area of dense enhancing soft tissue. This is observed in association with enlarged left axillary lymph nodes. It is important to remember that breast imaging is better performed by ultrasound, mammography, or MRI. Although CT scan of the chest is not the way to go for imaging breast lesions, such abnormalities should not be missed. The tissue diagnosis from this area turned out to be breast cancer, and these were positive lymph nodes. Before I show you the next finding, I'd like to revise some vascular anatomy. This is the aortic arch, which gives you the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. As you go distally, the brachiocephalic artery divides into the right common carotid and right subclavian arteries. Now that you know that this is the right subclavian artery, you'll notice that the vessel in front of it represents the right subclavian vein. This is true on the left side as well, subclavian artery and subclavian vein. Looking carefully, you'll see that there is this small vessel that arises from the proximal subclavian artery and runs in a parasternal location here. The same is true on the left side, so both these arteries are the internal mammary arteries. And as you see here, each internal mammary artery runs along with an internal mammary vein. This is also true on the left side. Artery and vein. The important rule is you shouldn't see any soft tissue components in this region. The only thing you should see is the internal mammary artery and vein. Identifying any additional soft tissue components represent internal mammary lymph nodes, which should never be seen. An internal mammary lymph node, no matter what the size is considered abnormal. Now, this is even more significant in the context of breast cancer, where internal mammary lymphadenopathy is a common abnormality. If you look on the right side, you'll notice that you only see the artery and the vein. However, on the left side, you'll see the soft tissue here. So in addition to the artery, the vein, there's an enlarged lymph node which is also metastatic. Such lymph nodes should not be missed on chest CTs, especially those done for lymphoma or breast cancer. Detecting internal mammary lymphadenopathy is difficult but is important, since if this is mentioned in the report, it changes the management. Once these lymph nodes are known, internal mammary area radiation may be performed. If this lymph node is missed, this could be the region of recurrence. We learned from this case to look at the soft tissues, the breasts in particular. We also learned that CT is not the best way to go with breast lesions. However, you may see important abnormalities. When looking at cases of malignancy, don't only look at the axillary lymph nodes, make sure you don't have other lymph nodes such as the internal mammary ones. In normal cases, you should only see the internal mammary artery and the internal mammary vein. Any soft tissue around it represents an abnormal lymph node. The main observation here is widening of the mediastinum. An additional finding that confirms the abnormality is the lobulated appearance of the mediastinum on each side. This is what you could call, in an elegant way, a contour abnormality. It's important to decide whether you think this abnormality is in the anterior mediastinum, middle mediastinum, or posterior mediastinum. Since you could see the hilum and the vascular hilar markings through the abnormality, this suggests that it's very anterior or very posterior. This is called hilar overlay sign, meaning that the abnormality is not arising from the hilar region or from the middle mediastinum. So now that you decided that the abnormality is either in the anterior mediastinum or posterior mediastinum, how would you differentiate? The easiest thing is to know what lives in the anterior mediastinum or the posterior mediastinum and see if that structure is obscured. Obscuration of the adjacent structure border is a silhouette sign, and it gives you a hint to the location of the abnormality on chest radiographs. Notice how it's easy on this radiograph to see the border of the descending aorta, so the descending aorta is not obscured. On the other hand, notice how you have obscuration of the aortic arch. You should see an aortic arch here. Obscuration of the more proximal segments of the aorta tells you that this is likely in the anterior mediastinum. Lack of obscuration of the descending aorta tells you that this is not in the posterior mediastinum. So from the frontal radiograph, you're suspecting this to be in the anterior mediastinum. In real life, don't be afraid to look at the lateral radiograph because that is really useful. I'll give you a chance to look at this and decide for yourself. We'll continue with the abnormal case. This is a normal case for the sake of comparison. On this normal lateral radiograph, you see the sternum. The retrosternal space here should be dark. Let's go back to our abnormal case. You'll notice that the retrosternal space is obliterated by what appears to be a white abnormality. This is another confirmation that the mediastinal abnormality is really located in the anterior compartment. And here's the CT on the same patient, confirming the anterior mediastinal soft tissue abnormality located here, displacing all the vascular structures posteriorly. The differential diagnosis of anterior mediastinal lesions could famously be remembered by the 4 T's. The first T stands for thymic abnormalities, such as thymoma and others. The second T stands for thyroid abnormalities, and that's when a thyroid lesion descends into the chest through the thoracic inlet. The third T represents one of the germ cell tumors known as teratoma. So germ cell tumors such as teratoma. The fourth T is not a T, it's lymphoma, but for us to remember it, we're going to call it terrible lymphoma or T-cell lymphoma. Given that this patient was a young patient without clear thyroid abnormalities, the differential diagnosis was either lymphoma or a germ cell tumor. The final diagnosis here was a lymphoma, which was treated by chemotherapy, and the patient did well. So this was a nice case to talk about an approach to differentiate anterior, middle, and posterior mediastinal abnormalities from chest radiographs. We also showed an example in which the lateral is not as scary as we think. It's actually useful, so always look at the retrosternal space and it should be clear. We finally talked about the differential diagnosis of an anterior mediastinal lesion, remembered classically by the 4 T's. Which brings me to my last T of the day. Thank you for watching. See you later.